Thank you, Neil, thank you, Enrique. Actually, I didn't, for allowing me to speak about what the VA does with COPD. I think this gives you an idea of the new logo of the VA, Defining Excellence in the 21st Century, and this is the West LA VA. And I'll just provide some background information and then give you an idea of what's done with patients who have COPD in the VA. So I think that I want to echo Dr. Simon's remark about how many people have COPD in the U.S. and the world in the VA system. Well, unfortunately, I can't give you a specific number because we don't really know, and although we've tried to get an estimate, but it's probably at least 20% of our veterans, a little more male than female, have COPD. It's actually the fourth most common discharge diagnosis in the VA. Fifth most common diagnosis overall, and when you consider there's over 25 plus million veterans in the U.S., this is quite a large number. It's very clear that there's over 500,000 outpatients with COPD that are treated annually in VA clinics. Now, what about GLA, Greater Los Angeles? Greater Los Angeles has an catchment area that encompasses about 500,000 veterans in the Southern California area. I was looking at some numbers recently, and in 2007, Greater Los Angeles had over 1 million outpatient visits in that one fiscal year itself. So I think it's very large group of patients that are addressed. The healthcare costs of COPD are obviously very high. Directly, at least $3 million, and this is actually this was in 1997. So it's much higher. And I think that some of you in the audience may or may not know, but there are issues in Congress that have redefined the eligibility for VA care. VA care actually is open to anyone who served at least one day of active service in the military. But it's all about space availability. And so that there are different tiers. I won't tell you about the different tiers, but suffice to say that there's only enough space to accommodate those who are service-connected and other issues involved with the military, and then those who obviously don't have the funds to for healthcare costs. And there's categories that range from 1 to 8, and our President Bush actually opened it up to all veterans, all categories, but that had to be suspended because the demand outweighed the resources. So anyway, so I don't, it's really not clear, but the one thing that's clear is that there is a consideration to have COPD as a service-connected disability. Those of you in the Veterans VA system may not know, but if you acquire a condition while you're in military service, it's classified as service-connected. And service connection ranges from 0 to 100%. Well, service connection comes with not only the disability payments, pension, but also access to care. And so I think that there is an issue here that in time it will exceed even what direct healthcare costs are at this current time. But what about people who get in the VA? Well, clearly that we know that patients with COPD diagnosis twice as likely to be hospitalized. They have longer hospital days. This is a little old data. 12 days is certainly no longer the norm around at any VA anymore, but certainly the costs for a VA patient with COPD are 5 times at the cost with a VA patient with asthma. They often are older, they have more comorbidities. You know, here you have 2/3 with one and 1/3 with more. The mortality rate is around 9% for all patients with COPD as a diagnosis. And so that's, at least in the VA system, it's the 7th highest. But it's really the one thing that's really clear. It's the only cause of death that has seen an increase in the death rate, compared to death rates that have decreased for all the other major conditions such as heart disease, cancer, and stroke. So the VA recognizes it has a problem. They recognize that the problem is related to smoking. They recognize that smoking is very common in the military system. It's really not clear how many veterans smoke, but certainly if you take 20% roughly of the U.S. population as smokers, depending on the part of the country, well, the VA has a much higher rate. Somewhere between 30 and 40% of veterans smoke. And so that because of this, that increases the risk of developing later on in life chronic obstructive pulmonary disease. And so the VA in the conjunction with the Department of Defense, has published and has created and published several guidelines on how to manage patients. And this, I'll just go through some of those with you. This is about 5 years old. What we had a local Veterans Administration physician, Dr. Michael Littner, involved with this. And so there's both LA and national involvement with this. And I'm sure that those in the audience will be familiar with many of the people who are involved. And so this is a little hard to read, but it just tells you this is how you start off. You suspect somebody has COPD, you think they have symptoms of the cough, sputum, or phlegm, dyspnea, and you determine if they're exacerbating, but then you proceed to identify, if they've had smoking, examine them, get a spirometry, identify this, and go through these. I'll go through these in a little more detail. It's a little obviously hard to see with this small, but these are sort of like page A of the guidelines. And so the major components. So what are the major components? And just to summarize, obviously if you have to make the diagnosis. Diagnosis is made with spirometry. Unfortunately, the VA is no different than the rest of the world or country in terms of diagnosing COPD. If you, if a third of the patients with COPD have spirometry, that's exactly the amount of number of patients who have, in a VA audit, have had spirometry with a diagnosis of COPD. So what about the other 2/3? Well, it's all clinical, but so only a third have that. Major emphasis on smoking cessation, pharmacotherapy, vaccination, pneumococcal influenza vaccine, oxygen therapy, rehab, and surgical options are not as available, but they are available, so that for the select patients, patients may be candidates for surgical options. And so what about tobacco? Well, tobacco is actually the single most preventable cause, a single condition that easily treatable and preventable cause of COPD, lung cancer, and a number of maladies. And so this is really a major emphasis in the VA system. And so you can see here there are flyers, posters that actually are throughout many of the VA hospitals. This is a VA-created poster that sort of highlights, smoking cessation programs are available. It's they recognize it's the hardest thing that you can do. To paraphrase Mark Twain, his comments about stopping smoking is the easiest thing in the world to do because I've done it 100 times. Well, that sort of underlies how actually difficult it is to stop smoking. And so certainly ask your provider. But as you can see here, they target also, their community. And so there's women involved. There's patients of color, African Americans. And so you can see that they focus on patients who may have this risk, and they tell them it's never too late to stop smoking. And so what's the model? The model here is they go through, there's 5 A's, and I'll just give you an idea about what is the guidelines in terms of a patient you see in clinic. You ask them, do you smoke? Yes or no. If you don't smoke, have you ever used tobacco? Yes. So you ask, you assess, have you quit recently, or if there's problems with maintaining this, and you go on. If you do smoke, you advise to quit, you willing to quit now, and then they assist. And so this is a sort of a focused approach because, and then this is a poster that outlines the guidelines. You can see it's a little harder to read, but I've taken a snapshot from our electronic medical system. And so our CPR system has been around for actually decades. But anyway, every provider who logs on will see this as a reminder. And so you can see there's many things that our patients the providers are reminded to do. And this is one that someone who's had a lot of reminders to be done. But one is tobacco use for surveillance. Asking if they do smoke, you click on that, you go through some point and click that helps them identify what is, if they are at risk for or willing to stop smoking. And you can see that if you go to the console, this is an order entry menu, console screen. There's a quick smoking cessation button. Click on that. You have 3 choices. You can tell them to, if they're depending on what the patient wants to do, to go telequit, which is something they can do using telephonic or web-based assistance, a smoking cessation clinic, something for people who need a little more help. Or some patients or some physicians decide, well, I can take care of this. It's not that difficult, although this is not an item that a lot of people take, but it's just something that's done. And then because it's a little easier to do than you have a relationship with a patient and come back, and so you click on that, you get another order entry menu that tells you what sort of medications that are appropriate to use in contraindications, and you point and click and order, point, click, and da-da. Sign the order, and it's patients are on their way. But so what about things available? Telequit. Telequit's a program that is patients phone in, and there are people on the other line who can help them get through smoking cessation. Often this is there's not much. There can and cannot be medications involved. Usually, obviously, we do have medications, but the patients have someone to contact all the time whenever they have the need for a cigarette fix. They call somebody. So what about web-based? There's web-based programs. There's this is the standard VA web-based program, and it gives you information. And when you hit quitting smoking, there's actually another web-based, which is co-sponsored by the Department of Defense. It's a You Can Quit Too web-based program. And the thing that's neat here is it's something special for the vets, but also there is a web-based program where if you don't have a phone or you don't want to use your phone, you can go on the web and somebody can interact with you live in terms of helping you stop your cigarette cravings or adjusting to smoking cessation. So this is guidelines that are outlined in terms of treatment guidelines. You can see that it's sort of somewhat complex, but it says you figure out if they how much they smoke, and if they don't want to go through these web-based programs, then you can try and use medications to help them through this. Nicotine replacement therapy, Wellbutrin or bupropion, or some combination thereof. If they relapse, there's stepwise progression to other agents, including Chantix or varenicline. And so I think that you can see here they describe in detail in posters what you can do with the nicotine patch or nicotine lozenge, how that can be used, titrate down to the amount of cigarettes that are done or smoked, and then using here progressing the nicotine gum. Gum is an option that some people don't realize. You don't chew like gum; you chew it to get to the nicotine until it starts to get a little tingling sensation, and then you leave it there, and then when it subsides, you chew it some more. So it's not quite like gum chewing, but it's also a nicotine replacement product. And so sometimes you need more than a patch and gum, and you can patch and lozenge. Sometimes you need a pill. Here it's bupropion or Wellbutrin. That's another agent that's used. Or you need both, a patch or some replacement item and a pill, or something that has or Chantix, which is varenicline, which is used as another adjunct. And so those are all things that are done for smoking cessation. All right, well, say they stop smoking. Well, they still have COPD. They still have symptoms. And often what's used is pharmacotherapy. The pharmacotherapy in the VA is a little different than the GO guidelines. GO guidelines are based on spirometry amount. So the VA guidelines recognizing that if 2/3 of your patients don't have spirometry, how do you know how you're going to treat them? Well, right, good question, right? Well, they all have symptoms. You don't treat them unless they have symptoms. And so this is a symptom-based guideline. And I think that if those of you in the audience who are familiar with the other guidelines will recognize that this is no different than the GO guidelines, where they separate out patients into mild, moderate, and severe disease in terms of how they control and using certain agents. Short-acting beta agonists or this is what these initials stand for. But nowadays we all call them LAMAs. LAMAs, it just sounds when we talk about this what we're talking about on code. But short-acting beta agonists, short-acting anticholinergics, long-acting beta agonists, long-acting antimuscarinics, ICS or corticosteroids. And then if, in addition to medication, other interventions always smoking cessation, vaccination, or rehab, especially if they're advanced. So, a very vigorous vaccination or program. The VA has, in all their hospitals and all their clinics, a walk-up flu clinic. So they open up shop, they open up in October, they run into January, and all you have to do is go up and get a flu vaccine. And so, obviously, after signing the waivers all, but there's no lines, don't need an order, just go up and get your shot. And so this is there's a patriotic approach, and then there's a little more, practical approach to exhorting patients to get their vaccine. So, what other things are involved? Well, there's we have a pulmonary consult page. There's oxygen evaluation that we can do and other tests. There's a rehab that we send patients to. I'm going to end up pretty soon. There also is another website that's allows. It's called PERC, Patient Education Resource Center. It's an acronym, and then it has other areas that they can click on to get information. And these are things that the provider can also have patients get at their clinic visits. So one of these is a written guidelines as to management. And here you can see there's, this is the COPD section, breathing techniques, COPD, pulmonary rehab. And I think the thing that's important is that you should know that this is available both in English, Spanish, PO is Portuguese. There's some of these guidelines are in like a dozen languages. And so it's encompasses many groups of patients who may have a language that's not first language isn't English. And so this is a part of that I bring up because what you can do is that you can print from this. The provider at the clinic visit can type in the patient's name, special instructions, even information. What is COPD? And you see these are pretty standard informational items, but these are things that sometimes patients don't recognize and they can take with them. And if they're on oxygen, they can tell them how to use the oxygen, what kind of things they have involved. And so you probably saw that list. There's a whole list of things that are available for patients with COPD and treatment. And then if they leave the hospital, they get hospitalized, they get information that tells them, what you do if you have problems after you get hospitalization, and what you should do after you get out of hospital. And I think that number one on the list is always to stop smoking and keep yourself from getting infected, taking your medications. We do other things. We involve in patient education. This is an article that we provided for the federal physicians in terms of identifying diagnosis of COPD, just informational primarily. But there are other programs out there. There's a program out of the Midwest. It didn't actually, the follow-up to this didn't actually work so well, but at least it's a VA combined randomized study, mainly of Midwest patients, where they had patient self-management. They did seem to have improvement in their outcome. And then certainly this is something, I don't know if Dr. Neal is here yet, but something I see here in the back, and something we work with Breathe California with in terms of a internet-based program. And so these are all things that the VA is involved with, both with patient care, but also education, smoking cessation, treatment, and then research. And so I just want to give you an idea about Greater Los Angeles. Greater Los Angeles is actually most of Southern California. This is our catchment area. And so that we have a hospital that's in West LA, but you can see we have large clinics that are in the Santa Fernando Valley, Sepulveda, Los Angeles is a downtown clinic. But there are also clinics that throughout the LA area, Lancaster, Pasadena, Oxnard, Santa Barbara, Santa Maria. And so you can see that it's actually quite a large amount of area. That you can understand why there's over 1 million outpatient clinic visits a year. And there's 2 nursing homes, one at Sepulveda and one at West LA. That's a community living center is that. And so this is the West LA VA, and I'll be happy to answer questions about COPD in the VA.